Okay, we're moving along in Unit 4 for Pharmacology. We're looking at Chapter 28, Complications of Insomnia. We all know what insomnia is. So there's lots of complications as shown on the slide. We use benzodiazepine receptive agonists, which is like Ambien, Sonata. And you really have to watch those. We hear a lot of negative stuff about Ambien and Sonata. Benzodiazepines like Restoril, Dalmane, Prosom, and then barbiturates, phenobarbital. Other drugs are antihistamines. We've talked about Benadryl, Dramamine certainly helps for insomnia. Sedating antidepressants, trazodone, amitriptyline, and doxepin are sedating antidepressants. Trazodone is often used with elderly patients when they're having sundowner syndrome. I think that's sort of interesting. That certainly does help our sundowner syndrome patients. And then skeletal muscle relaxants. As we all know, if you sprain an ankle and you take a muscle relaxant, then you get really sleepy. Restoril, this is the package insert. Nursing considerations for insomnia meds identify why they can't sleep. And in this picture, you'll see energy drink. Certainly those can cause all kinds of problems, but insomnia being the one, because that's why people take them, where they can stay awake and do what all they want to do. You need to do non-pharmacological pharmacological meds first, and then perhaps use a prescription. These prescriptions should only be taken short term, and a side effect then would be drowsiness, blurred vision, don't need to operate a car, etc. Narcolepsy is a strange phenomena where patients just want to go to sleep, and they sleep at inappropriate times, and the brain can't regulate that sleep-wake cycle. The medications for it are Ritalin. That's what we give our children for hyperactivity. And it's a CNS stimulant. You need to watch for hypertension, palpitations, tachycardia. Provigil, I've never given that. And Extrum, I've never given that. But you see, they cause all kinds of CNS stimulants or depressants. And the last one can cause sleepwalking. So in any of these kind of meds, we need to watch for other sedating meds that can go along with it. And especially, we need to always be advising our patients not to drink alcohol at the same time. So I'm looking here quickly in the Chapter 28. Remember that the benzodiazepine receptor, I said, were the less likely to be addictive, but they still have to be carefully monitored. And need to know what the common drugs are, what the categories are. We've talked about the benzodiazepine receptors, and that's the ones that's less likely to be addictive. But Lunesta, Ambien, we've heard about those. Sonata is another one that they take at bedtime. And then you need to know the adverse effects, and we talked about sleepwalking, how these drugs can also affect the liver and kidneys and can hurt the kidneys. They're metabolized by the liver and excreted by the kidneys. So people with liver disease, we've got to watch for that. You can certainly have overdoses on benzodiazepines, which is the second category. And Romazicon is the reversal agent. You need to know that. And was trying to see, Restoril is a very common one. Benzodiazepine, you'll give Restoril. I used to give it a lot. I don't know that it's given that much now in the hospital, but Restoril was very common for insomnia. And but you have to have Romazicon ready because they can overdose on that. Be sure and read about that on page 453. What to do, what to teach the patient, what happens if you're pregnant, etc. You need to know all of the intended responses, the side effects, the adverse effects, what to do before and after, and what to teach your patients. Older adults, certainly we try to give a lower dose, a half a dose, something like that. And we always will want to assess their level of consciousness, and they are not to drive. And going back to my previous video, make sure on page 112 you know the key points about pain. It's a very good summary of chapter 7, key points. I meant to tell you that earlier. Okay, moving on. You find it in my textbook. We're going to go to chapter 30. Drugs for osteoporosis and arthritis and skeletal muscle relaxation. Bones must stay firm and dense throughout the lifetime. Certainly they hold our body up. And bones are formed with the removal of old bone cells, which are called osteocytes, and they're replaced with new bone cells. And that goes on throughout our life. This is called osteoclastic activity. It's the process of old bone cells being replaced with new bone cells. This activity also causes bones to lose minerals, especially calcium. So thus the reason we have osteoporosis. So it's the natural physiology of the way our bones stay firm throughout our life. And this replacement of osteoblastic activity, and as we grow older, this activity slows down, causing an imbalance. So that is how osteoporosis occurs, which I find very, very interesting, how the body knows to remove these old bone cells, put new bone cells as the children are growing and throughout our life. And then sometime people have a slow activity and they develop osteoporosis. Very interesting. Drugs used to manage it are nutritional supplements that have calcium and activated vitamin D, bisphosphonates, estrogen, and osteoclastic monoclonal antibodies. So we give our patients calcium and activated vitamin D, and that is because calcium that helps calcium be absorbed in the intestinal tract. Bisphosphonates is a type of calcium modifying drug that both prevents bones from losing calcium and increases bone density rather than just maintaining it. So it helps increase the bone density. And its major use is the prevention and management of osteoporosis. So Fosamaid and Boniva are two of the common meds used for osteoporosis. And please note they both have DRON in the middle. Good way to remember it. The most serious adverse effect is the development of jawbone necrosis, especially with tooth extraction of other invasive dental procedures involving the jawbone. So the jawbone can actually necrose, and therefore if you're on any of these osteoporosis drugs, so you need to have regular dental checkups. estrogen agonist and antagonist, hormone receptor drugs that selectively bind to and activate, which are agonists, estrogen receptors. So they bind the estrogen in some tissues and bond to and block estrogen in other tissues. They assist in preventing bone density loss. So these hormone receptors get out of balance, and so these drugs help them attach to some tissues and bond and not attach to others. And that Evista and then Duvi, those are two, but Evista I've heard about. But they can cause, when you start messing with your hormones, you can get tumors, blood clots, thickened uterine lining. A lot of stuff goes on when you start messing with your hormones. They can increase the risk for thrombolytic events, including deep vein thrombosis, stroke, MI, pulmonary embolism. And you cannot use this with anyone who's had a previous thrombolytic event or who smokes. Okay, osteoclast monoclonal antibodies. These are drugs are composed of antibodies directed against immature osteoclasts. So they fight against these immature osteoclasts. Binding of these antibodies to these immature osteoclasts prevents them from maturing and reduces their action of reducing bone density. So by binding to them and making them die or whatever, they don't reduce bone, they stop the reduction of bone density. And you can have severe allergic reactions to this, but Prolia is the one you see advertised usually on TV. The adverse effects are this jaw osteochronosis, and I had a friend that happened to, and she had to have all of her teeth on the bottom pulled and had to have implant on the bottom. Severe allergic reaction, and we need to make sure they have regular dental checkups. Then here's the normal hand and arthritic hand, of course, and the inflammation. Remember the signs of inflammation: redness, swelling, pain. The types of arthritis are osteoarthritis and rheumatoid. Osteoarthritis is a wear and tear disorder in the weight-bearing joints from repetitive motion. So if you type all day, play on your phone all day, by the time you're my age, you are going to have some arthritis in your hands. It's not caused by autoimmune or inflammatory disorder, but you can have joint inflammation. Rheumatoid, however, is an autoimmune disease in which the immune system fails to recognize cartilage and other joint tissues as normal and attacks them. Very severe and painful disease. Psoriatic arthritis is an autoimmune disorder also, and they have skin manifestations of psoriasis. Is the inflammation is from the tissue destruction, and most commonly found in the feet, hips, and lower spine. Gouty arthritis or gout. This is a problem that stems from excessive uric acid crystals in the blood called hyperuricemia, and it goes in the joints and starts an inflammatory arthritis with pain, swelling, inflammation. It's normally found in the foot or in the big toe, but it can go into the knee joints and other joints. But usually gout is in the foot, in the toe. Now there is a gout called pseudogout, and it is not from uric acid crystals, but it's a calcium issue, and it usually affects the knees. So we use anti-inflammatory drugs, NSAIDs, which we studied in Chapter 6. They take hyperuricemia meds for the gout, and those reduce the blood uric level. And that's allopurinol or Xyloprim. And then they can take enzymes called Elitech. But the gout uses a certain drug that decreases the uric acid level. Okay, muscle spasms, that's an involuntary contraction of a single muscle or group, and it's pressure on the nerve, swelling along a nerve path, or an electrolyte imbalance. There's that calcium and magnesium again, so important to our body. We can take relaxants for that, which depress the central nervous system. And these are some of the Flexeril, one of the most common. Side effects, very much for these other pain meds, fainting, dizziness, hypotension, bradycardia. And adverse effects are dysrhythmias. You need to study those on page 477. Let me look it up real quick. Common side effects, fainting, flushing, hypotension, bradycardia, as we've talked about. Dysrhythmias. Certainly bradycardia would be probably one of the most dangerous dysrhythmias, and you need to read about that. Prolonged cardiac conduction. We studied about the prolonged. If the PR interval is prolonged, then it's taken longer to get that conduction through the heart, which is not good at all. That will cause a slowing of the heart, the bradycardia. And so you need to be very, very careful about that. And these two meds should not be given to anyone who has seizures. And that is the end of the discussion. I knew that those two were going to be short, but so hopefully this will help you on Unit 4. I have gone through and looked through the book as I have discussed this to try to give you an overview. Key points there at the end of Chapter 30. You need to look at those. Look those in any of the chapters. Very important to look at those key points, and as I've told you before, the terms at the beginning of the book. Okay, thank you very much.